Okay, members, I'm going to call Human Services, Finance, and Policy to order. Ms. Hanson, will you take the roll? Chair present.
Schultz present. Vice Chair Bonner.
Present.
Lead Albright.
Present.
Representative Bolden.
Present.
Representative Burkle.
Burkle present.
Good morning. Representative Fisher.
Fisher present.
Thank you. Representative Frederick.
Present.
Representative Hanson.
Present.
Representative Keel. Representative Liebling.
Present.
Representative Mueller.
Present.
Representative Noor.
Present.
Representative Novotny.
Bonnie present.
Thanks. Representative Pearson.
Present.
Representative Pinto.
Present.
Representative Rasmussen.
Rasmussen present.
Representative Robbins.
Present.
Representative Sandell.
Present.
And Representative Schumacher.
Schumacher present.
And Representative Keel, I see you just joined. Welcome. We have a
Thank you.
quorum, Chair Schultz.
Thank you, Ms. Hanson. We have a quorum. The next order of business is to move the minutes. Representative Albright, would you like to move the minutes from March 8th?
So moved, Madam Chair.
Thank you. Representative Albright moves the minutes from March 8th. Are there any corrections? Not seeing any hands. With that, members, please unmute yourself. All those in favor of approving the minutes from March 8th, 2022, please say aye.
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 Any opposed? Okay, the motion prevails and the minutes are adopted. Okay, first up on our agenda, members, is House File 2773. And Chair Liebling, I see that you have an A1 amendment. Would you like to move that amendment?
I would, Madam Chair. It just changes the effective date.
Okay, Chair Liebling moves the A1 amendment to House File 2773. This is a voice vote, members. All those in favor, please say aye.
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 Any opposed? Okay, the motion prevails and the A1 amendment is adopted. Okay, my motion is to lay over House File 2773 as amended for possible inclusion in our Human Services Omnibus Bill. With that, Chair Liebling, please tell us about your bill as amended.
All right. Thank you very much, Madam Chair and members. This is a House File 2773 is really a very simple bill. It corrects an unfairness in eligibility for medical assistance. So before the Affordable Care Act came into being, eligibility for MA was both categorical and income-based. The ACA removed the categorical basis of eligibility, so adults without kids were no longer excluded if they met income and other requirements. And as you know, I'm sure the income eligibility for MA is generally 133% of the federal poverty guidelines for parents, children 19 to 20, and adults without kids. But it didn't change for elderly and people with disabilities, and the income eligibility is 100% of the federal poverty guidelines. And just for context, for a single person, that is only $12,888 a year. Think about that, how low that is, $12,888. And there's another way to be eligible, and that is spending down. So a person with high medical bills can apply those and spend down until they reach a level at which they become eligible. But that level is 81% of the federal poverty guidelines. So think about that. That's only $10,440 for a single person. That's shockingly low. What a person has to spend down to become eligible for medical assistance if they're elderly or have a disability, and that's the basis of their eligibility. So what this bill does is it changes eligibility to 133% of the federal poverty guidelines, which is generally the same as other categories. And we have, as you all know, we have a large surplus. The surplus is likely to continue. And I think it's time, since we have the funds, I think it's time that we treat people who are elderly or have disabilities at least as well as we treat other people when it comes to MA eligibility. And by the way, this doesn't fix everything, but it would be a big step. So, and also just so everybody knows this, we did change some of this a few years ago and we put it out in the future. And so as of July 1st of this year, the spend down, I think it is, will be 100%, not 81% of the federal poverty. So we started to fix this, but we have a ways to go yet. And that's what this bill is attempting to do. The amendment was just pushing out the effective date because I got technical assistance from DHS that they just couldn't implement it any faster. So it unfortunately pushes it out to July of next year instead of January. But I just feel so strongly that this is at least something we should be considering in the mix with other ways that we're going to try to improve our medical services for folks in Minnesota. And just remove this really unfair situation. So with that, members, I think there were a couple of testifiers on the bill, and I'll turn it back to you, Madam Chair. Thank you.
Thank you, Chair Liebling. This really does address equity, so I'm so glad that you brought this forward to the committee. So the first testifier we have is Maren Holden. Please introduce yourself, Ms. Holden.
Thank you so much, Chair Schultz and Representative Liebling and members. My name is Maren Holden, and I'm an attorney at Legal Aid, which includes the Minnesota Disability Law Center. And we are so grateful, Representative Liebling, for you bringing this bill because it would address a longstanding problem and inequity in our Medicaid program for people who have disabilities and elderly folks. Many people who have disabilities have really significant healthcare expenses or long-term support needs, including things like PCA, and Medicaid is often the only option for meeting those needs. But for years, in order to access Medicaid, as Representative Liebling was mentioning, people with disabilities were required to spend down to lower than the federal poverty guidelines, meaning that they were required to spend their own income on healthcare and disability supports down to a level lower than federal poverty guidelines. And this has just been incredibly difficult for our clients. They're often so surprised. They've jumped through all the hoops they needed to become eligible for the Medicaid supports that they need. And then they have to turn over a significant chunk of their limited income to pay for it. So if as Representative Liebling was saying, if you have even a very small income, something like $1,200 per month, right now, someone still needs to spend that down to only about $800. They could be spending $400 a month to qualify for Medicaid. And as we think about it, that essentially makes this a high deductible plan that requires some folks to pay nearly a quarter of their income for that deductible, which very few of us pay a quarter of our income for our healthcare deductible. Thankfully, the spend down will change in July to match the income eligibility of 100% of federal poverty guidelines. And we are so grateful that the legislature made this change. And we're talking about having a party in July when that goes into effect. But that income eligibility standard and spend down level is still lower for people who have disabilities and elderly folks than other eligibility categories. Most of those eligibility categories in the same subdivision, if you look at it, are all 133% of federal poverty guidelines, not 100%. And so we are really supportive of this change in House File 2773 to raise that income eligibility standard from 100 to 133, which would also raise the spend down to 133 because they're cross-referenced. This would mean that people who have disabilities would not be subject to such dire poverty in order to receive their needed health and disability services. Folks who have worked and are now disabled and receiving SSDI would be able to keep more of that income, and that deductible would no longer be so high. We also think it would make this program more streamlined. With a spend down that's more in reach for a lot of people, far more people will sign up to do the pay the state option with their spend down rather than directly to providers, which will mean more consistency for participants, providers, and for the state. Honestly, the current Medicaid income and excess income standard drives people who have disabilities into poverty and makes folks poorer than poor. And we just think people should not be worse off either because they're poor or disabled in a program that's supposed to be designed to help take care of people's medical and disability related needs. This would be a tremendous relief for our clients and folks in the Medicaid program. And we think it will make the program fairer across the board and easier to administer. So thank you so much, Representative Liebling, for bringing this important bill, and Chair Schultz for the opportunity to share Legal Aid's views. We're really grateful.
Thank you, Ms. Holden. The second testifier I have is Rebecca Preston. Please introduce yourself, your affiliation, and then proceed with your testimony.
Hi, my name is Rebecca Preston. I am a citizen advocate for the Minnesota Brain Injury Alliance. I live in the Dover Hill Apartments in Golden Valley. I have lived there for almost 6 years. I have a traumatic brain injury that I obtained in 2005 when the car I was driving was T-boned by a drunk driver. Today, I do not have a driver's license. I have severe cognitive disabilities, double vision, concentration issues, and a balance disorder. Because the highway between the two lobes of my brain was severed, I no longer play the piano, write short stories, read fiction, or knit. Those things were part of who I was, and I thought I could never live without them, but I am. Medical assistance, known as MA, has been and continues to be very important for me. It provides health care and services that allow me to live independently. I have had an independent living skills worker who has helped and taught me how to interpret my mail and keep my house organized. She also brought me out into the community and taught me how to have fun. Since having the TBI, I haven't been very good at having fun outside my home. I also had an arms worker, adult rehabilitative mental health services. She would talk to me about how my week was and help me be my own best advocate. I have graduated from these two programs and now have an in-home worker who is a person who picks me up and takes me out into the community to run errands and to do my grocery shopping. I also have a home health care worker who comes over to help me clean my house. There is also a driving program at Courage Center that will assist me in getting my license back. All of these things, which are provided by MA, have been very, very helpful to me. Without them, I would probably be living in a bed. Before my injury, I had a 35-year work history, and like many people, was paying Social Security taxes since the first job I had. This allowed me to qualify for Social Security Disability Insurance, or SSDI, after becoming certified disabled because of my injury. The problem is that my SSDI income is $1,200 a month. It puts me over the income limit for MA, which is the only place where I can get the home and community services that I was telling you about. This brings me to the spend down, which for me means I have to pay $300 of that income back to the state each month in order to get medical assistance services. That does not leave a lot of money left for me to pay the other bills. I do want to say thank you very much to I do want to say thank you very much for improving the spend down situation, which means starting this July, my spend down payment will be closer to $100 per month rather than the $300 that I've been paying. Yay! But it is still money that I have to pay each month out of my own funds to qualify for MA. It still doesn't make any sense that because I am disabled now and for the rest of my life, that my income is so limited that it will barely pay my rent as well as my other bills. The MA income limit for people with brain injury and other disabilities desperately needs to be raised. Please support House File 2773 so that I can keep more of my Social Security disability income to pay living expenses and to get the services and supports I need to live independently in the community. Nobody really thinks much about what could happen to them if they become disabled in an instant, like what happened to me. I sure didn't. Nobody wants to need the Social Security disability they've been paying for their whole life, working life. But if they do need these benefits, it would be nice if the state of Minnesota didn't take part of those benefits away to qualify for MA. It is also unfair that people with disabilities are expected to live on such low income just to get health care and home and community services they need. I thank you so much, Chair Liebling and Chair Schultz, for authoring this bill, and I hope you will all support it and do everything you can to pass it this year. Thank you for listening to me.
Thank you, Ms. Preston, and thank you for pointing out the absurdity of having people spend down to poverty to get the health care services they need. We really appreciate your contribution today. So members, questions for the chair, Liebling, or the testifiers? We also have Jeff Nachbar on deck for questions. Representative Moeller.
Thank you, Madam Chair, and thank you, Chair Liebling, for bringing this. I just signed up to be a co-author. Really excited about this bill, and thanks to your testifiers, and especially Ms. Preston. You said yay for the upcoming change, and hopefully we can give you a double yay if we can get this bill passed as well. I do just have a quick question for Chair Liebling or anyone else who might know. I'm wondering what other states do if they also have this disparity with families and children and then people with disabilities.
So thank you, Madam Chair. And I can't answer the question completely, Representative Mueller, but so maybe Maren Holden can, but I would say this though. Not every state even expanded Medicaid, it's called medical assistance here, but Medicaid in most states. And a lot of states didn't even do that expansion. So I don't think we want to be necessarily comparing ourselves across the country on this, but I don't know the answer specifically. Maybe Ms. Holden does.
Ms. Holden?
Thank you, Chair Schultz, and thank you, Representative Mueller, for your support on the question. I don't know. I have a chart with all of what the income standards are, but it is my understanding that all states have some disparity, but I don't have a chart in front of me what that is, but I will look into it and get back to you.
Thank you, Ms. Holden. Representative Mueller. Okay, Representative Albright.
Thank you, Madam Chair. Representative Liebling, a couple points from a fiscal perspective. When we move to 133% for a elderly or disabled single, what would that annual amount then be?
Chair Liebling.
Madam Chair and Representative Albright, I don't know if you're asking just what the limit would be for them at 133. So according to the document that I have here from DHS, and I'm just comparing it now to what it says 133 is for other folks. So for one person, 133% of the federal poverty guideline is $17,130 a year, or $1,427 a month. Still a pretty low level. Nobody's going to get rich off of this change. That is very clear.
Right. Thank you, Madam Chair.
Representative Albright.
Just to follow on, in Ms. Preston's testimony, and by the way, Ms. Preston, thank you for your testimony. It was very compelling. I noted that she is receiving SSDI, and that seems to be prevalent, obviously, for a number of the folks in this group. That alone puts them over the limit. Am I correct in that? And based upon what amount they're receiving, is that not protected currently? Is there, what I'm getting at, is there a subrogation of the benefits here between MA and their SSDI, and they have to choose between one or the other? Or is it you have to take the MA and you have to deplete or not take as much SSDI as what you might be owed or deserving?
Chair Liebling?
That does sound like a question for Maren Holden, if you would.
Ms.
Madam
Holden?
Chair.
Thank you, Chair Schultz, and thank you, Representative Albright, for the question. Correct. Many of our clients, and it sounds like Ms. Preston is in a similar situation, need to use portions of their SSDI income to pay their spend down in order to remain eligible. So there's not some sort of a protection for most people on SSDI. There are some random, as you can expect, there's some weird little loopholes that only lawyers care about. But for the most part, folks using SSDI, and on average, that an SSDI monthly income is about $1,200. And as Representative Liebling said, right now, at 80% of FPG, I think that's about $870 per month. So that's why Ms. Preston is spending down $300 a month. When income July, that will move to more like $1,000. So folks will still be spending down a decent chunk of their average SSDI income.
Representative Albright?
Thank you, Madam Chair. Do we know, or can someone recall the fiscal note for when we moved it last term up to 100% of the FPG? What amount was that? And just anticipating, I don't see a fiscal note on this, but if we can get
Mr.
kind
Berg. Mr. Berg.
Madam Chair, Representative Albright, I don't have that number off the top of my head. I can look it up and send it to you. It was a significant amount. But I will point out it actually was not in the last bill. The move to 100% happened in the 2019 bill. Over the quite a few years since the late Representative Waffler started this progression through statute, the way this has typically happened is that some bit of the percentage has been nipped off way out in the tails to keep the costs manageable. But I'll find that number for you and send it to you.
Thank you, Mr. Berg. Representative Albright?
Thank you, Madam Chair. Representative Liebling, I share your concern for this, having seen a little bit of up close and personal. Has there ever been consideration of enacting a statute that just says they can keep their SSDI regardless of what economic situation they're in?
Chair Liebling?
Well, I couldn't tell you if there's ever been consideration of that. I certainly think that would be something we could consider, but this isn't only probably about people who get SSDI. So if you did that, I think you'd be limiting it only to one group of people. And as I understand it, it's pretty difficult to get on SSDI. So I think you might be really leaving out a lot of very, people who we really would all agree should be covered if you did it that way. But, and to your other point, Representative Albright, it is an expensive thing to do. And I know the members of this committee all understand that a lot of things we do in this committee, the reason they haven't been, people say, well, why didn't you raise the wages more before? Why didn't you do this? Why didn't you do that? It's because it does cost a lot of money. And, I think we have to, every budget cycle, we have to figure out what we can do with our limited resources. And in some cycles, we're even cutting the budget. So I just think right now we have an opportunity to really fix some things that we haven't been able to fix before. So thank you.
Representative Albright.
No, thank you for the answer and the responses, Representative Liebling. We are charged with being courageous about these programs and about the people we serve. So I appreciate your testimony.
Okay, I'm not seeing any other questions from members. Final words, Chair Liebling.
Thank you, Madam Chair, and thank you so much to the testifiers for helping me out here. Ms. Preston, thank you so much. That was really, really compelling and helpful. And members, during this hearing, it really occurred to me, there's a lot of discussion going on right now about Social Security taxes, right? I know this is a little off topic, but how do we help older people? Somebody like Ms. Preston, I don't think she's paying taxes on her Social Security. But, when we think about how do we help older people in the state, we've got lots of older people who need help with the revenue that we're bringing in. And I think that's something we really need to keep in mind as we think about who are the elderly people, who are people with disabilities in our state. And they're our friends and neighbors. And they are oftentimes, we don't realize how much of a struggle they are in just to get their basic services. So I so appreciate the testimony today, and thank you for considering the bill.
Thank you, Chair Liebling. With that, House File 2773 as amended will be laid over for possible inclusion in our Human Services Finance and Policy Bill. Okay, next up on the agenda is my bill, House File 4096. I'm going to hand the gavel over to Vice Chair Bonner. And I will move to lay this bill over for possible inclusion in Human Services Finance and Policy.
Thank you, Chair Schultz. So we have a motion then by Chair Schultz to lay this bill over. That is the motion on the table at present. And Chair Schultz, would you like to, I don't see any amendments. Would you like to go ahead and explain your bill?
Thank you, Chair Bonner. So House File 4096 provides DHS with the authority to develop a waiver to expand the use of presumptive eligibility for home and community-based services and alternative care. Presumptive eligibility is a Medicaid policy option that allows states to authorize certain qualified entities to screen eligibility to allow participants to temporarily access Medicaid without having to wait for their application to be fully processed. It's currently being used in some situations by hospitals today to determine eligibility for medical assistance or Medicaid for families and children who are hospitalized but are uninsured. With a shortened application, a hospital worker helps the family fill out the application and can be found eligible for Medicaid for 30 days while the full application is completed. But if you are a senior or person with a disability trying to access home and community-based services, we do not have this expedited process in place. For older adults, Minnesota has the Essential Community Support Program, the Alternative Care Program, Elderly Waiver, and other HCBS waivers that are trying to keep people in their homes. However, many Minnesotans are not receiving services quickly enough to remain in their homes between the financial and functional eligibility requirements. So this bill would simply adopt tools we use in hospitals to our home and community-based services programs by directing the agency to establish a presumptive eligibility process and submit a waiver to CMS for approval to utilize this new process. Among the many lessons we have learned from COVID is that we need our long-term care programs to allow people who are hospitalized or in need of long-term care services to remain in their homes. We know that Minnesotans want to stay in their homes, and helping them do so is less costly for our state budget. Several states have implemented presumptive eligibility strategies, and we are pleased to have Catherine Kinnaman here from Washington State to testify about using the 1115 waiver authority to develop different tools to speed up eligibility for senior programs and community-based waivers. But first of all, I'd like to hand it over to Mary Jo George with AARP.
And I believe we do have Miss George.
Yes, good morning.
Good morning, Miss George. If you'd like to go ahead and state your name, your affiliation, and proceed with your testimony.
Sure, thank you. Madam Chair and members of the committee, my name is Mary Jo George, and I'm the Associate State Director of ARP Minnesota. Joining me today, as Representative Schultz indicated, is Catherine Kinnaman from Washington State. So we're really pleased to have her with us today. We want to thank you for the opportunity to testify and also thank Representative Schultz for bringing forward this bill, which we believe will significantly improve access to home and community-based services for older Minnesotans and people with disabilities. As many of you are well aware, the COVID pandemic has been devastating to older adults, and it really laid bare some of the risk of institutional settings for these adults. At the height of the pandemic, nursing home and assisted living facilities represented close to 80% of Minnesota's COVID-19 deaths. So given what we have learned from the pandemic, we do believe it's important to reduce as much as we can reliance on nursing homes and offer people more choices. Unfortunately, today, I think Representative Schultz indicated this, older adults and people with disabilities have to wait 90 days often to establish eligibility for these public programs. And this inadvertently funnels many families who prefer home-based care towards nursing homes. Under presumptive eligibility, workers can use basic financial information and screening tools to quickly presume a low-income individual is eligible. The individual then can start receiving the services in their homes when the need arises and while the application is being processed. We believe by quickly providing continuity of care in the community, individuals can maintain their independence and avoid unnecessary admissions to nursing homes. We think Minnesota should build off the quick financial screening process that currently exists for the alternative care program and extend this policy of presumptive eligibility to other programs as envisioned in this bill. 5 states are currently using presumptive eligibility, and most recently, Indiana implemented a pilot program. In these states, what we have learned is not only have they been successful in keeping seniors in their home, but it has saved money too, as it costs on average 3 times more to care for a person in a nursing home under Medicaid. Finally, according to AARP's research, the financial risk that someone will be ultimately found ineligible was very minimal. And I think the studies show that it was less than 1% in these other states. And these costs then were either fully assumed by the state or shared with the federal government under the waiver option as proposed in this bill. So in conclusion, we're hopeful that the state of Minnesota would look to follow these other state leads, and again, are pleased to have Catherine Kinnaman here with us to share Washington State's experience. So at this point, I think I'll hand it over to Catherine. Thank you.
Ms. Kinnaman, do we have you here available?
Yes, I'm here. Thank you.
All right, Ms. Kinnaman, if you'd like to go ahead and state your name, organization, and proceed with your testimony.
Thank you. Good morning, Chair Schultz, Vice Chair Barnett, and members of the committee. And thank you for inviting me to join you today to talk about how Washington State is using presumptive eligibility. For the record, my name is Catherine Kinnaman, and I am the Deputy Director of our headquarters operations with the Division of Home and Community Services, which is at the Department of Social and Health Services in Washington State. I've worked for nearly 30 years with health and human services programs within the state of Washington in various roles at both the Department of Social and Health Services and also at the Healthcare Authority, which is our main Medicaid agency. I assumed my current role in spring 2019, and we provide an array of long-term services and supports for seniors and individuals with disabilities in Washington State, but our administration does not include individuals with developmental disabilities. In Washington, we have various Medicaid and state-funded only programs like Minnesota. We have 3 home and community-based waiver programs similar to Minnesota's elderly waiver. And we also have programs that are similar to the alternative care waiver and your essential community supports program. We also leverage the Community First Choice 1915K option to provide personal care services for both Medicaid recipients and our waiver recipients. And in addition, 5 years ago, we established an 1115 demonstration waiver with the Centers for Medicare and Medicaid Services that we use to create 2 programs to support unpaid family caregivers called Medicaid Alternative Care, or MAC, and Tailored Supports for Older Adults, or TSOA, which I will talk about shortly. In many ways, Washington and Minnesota are similar in that we both have a long history of making investments in home and community-based services and a shared commitment to serve individuals in home and community-based settings, reducing the unnecessary reliance on institutional settings. In Washington, when we talk to older adults and others who may need our services, we know they want to remain in their own homes. And we've worked hard over the years to ensure that our home and community-based service system is efficient and effective to help people age in place. I'm here today specifically to describe Washington's experience with simplifying the process of beneficiaries accessing the correct type of services for their needs at the right time of their life. I'm going to focus mainly on both financial and functional presumptive eligibility. And these are both tools we have been using to great success over the past several years, and they are the subject of this bill. So what is presumptive eligibility? So presumptive eligibility is a process by which a person applying for benefits gives some basic information either about their financial status or their functional need, or both, for services. And based on that targeted information, we can find them eligible and start services almost immediately. We also see presumptive eligibility as a way to help mitigate the institutional bias that is baked into traditional Medicaid-funded long-term services and supports. During the COVID-19 pandemic, Washington also leveraged emergency federal flexibilities to test other ways to expedite both the financial and functional eligibility determinations. And this proved a key factor in our COVID response, which helped mitigate the pressure on our acute care hospitals. In Washington, both our MAC and TSOA programs use a presumptive eligibility process. MAC is targeted towards individuals who are already financially eligible for Medicaid. So we use a short screening process to determine functional presumptive eligibility. And TSOA is targeted towards individuals spending down to Medicaid eligibility. So we use presumptive eligibility to screen for both financial and functional eligibility. The applicant self-attests to their income and assets, and the screener asks a series of simple questions to screen for nursing facility level of care. Once a person has been found presumptively eligible, some key services are able to be put in place to help stabilize the individual's situation pending that final eligibility determination. So why do we think presumptive eligibility works? Surveys of our MAC and TSOA program recipients tell us that this program works primarily due to the ability to connect people quickly to services when the need is the most urgent and before the decision is made to move a loved one to an institutional setting. When unpaid caregivers reach out for support for their loved ones, we believe it is critical to be able to act quickly to offer needed supports while waiting on a final eligibility determination. We have also demonstrated to our legislature that these programs save the state money. Current projected in-home caseloads are trending significantly lower today than the original November 2017 forecast for in-home personal care, which was prior to the implementation of the MAC TSOA programs, showing that providing rapid access to an array of lower cost support services delays entry into traditional, more costly LTSS. As a result, the Washington State Legislature has been able to take those funds and reinvest these savings. But what if someone is ultimately not found eligible for the program? Wouldn't that cost the state more money? Since our 1115 waiver was 100% federally funded money, CMS was keenly interested in the answer to this question and raised it many times during our 1115 extension and ongoing renewal conversations. However, the data we have tracked since the program inception has shown that this is a very minor part of the program, and the risk has decreased each year as staff have become more familiar with the screening process and received training. Since the benefits that are authorized during the period of PE are limited, the costs are also very low. I'd like to end today's presentation by sharing Washington's goals for the future related to expanding the use of presumptive eligibility. And as we work with the Centers for Medicare and Medicaid Services to renew our current 1115 demonstration waiver, Washington is hoping to expand the presumptive eligibility model demonstrated with our MAC and TSOA programs to our regular long-term services and supports programs. We're exploring ways to develop the right balance for the screening and assessment processes that allow an appropriate person-centered service plan to be put in place that quickly delivers services and mitigates the risks of clients being subsequently found ineligible. We believe the end goal of continuing to broaden and expand presumptive eligibility will be a key strategy in our efforts to remove the institutional bias in Medicaid long-term services and supports and continue our rebalancing initiatives. I thank you all for your time today, and available to answer any questions you may have. Thank you.
Thank you. I appreciate that, Ms. Kinnaman. And with that, we do not have any additional testifiers, although we do have a Mr. Burke and Ms. O'Connell here available for questions as well. And I do see two members have questions. First, Representative Robbins.
Thank you, Madam Chair, and thank you, Representative Schultz and the testifiers. You know, I'm really interested in this idea, but I do have some specific questions, probably for either Representative Schultz or Ms. Kinnaman. First, you know, I have the bill language up on my other screen, and it's very vague. So I just wondered, Ms. Kinnaman had referenced that the people who use the presumptive eligibility are only eligible for limited benefits. So I'm just wondering, what is your intention, Representative Schultz? Would they be able to access all benefits immediately under presumptive eligibility, or would it be limited? And I'd like to hear from Ms. Kinnaman what those limited benefits are in this first presumptive phase.
Thank you, Representative Robbins. I would leave it up to the agency to work with Washington State on a similar 1115 waiver, because we know CMS has approved that. So I think they would start there, but I think a lot of the details will be worked out in that waiver language.
All right, thank you, Chair Schultz. Ms. Kinnaman, did you have a response as well?
Thank you, Madam Chair and Representative Robbins. I'll let you know that on the MAC and TSOA programs, because it's directed towards family caregiver programs, we developed a tiered structure on how we deliver those programs. And so that initial benefit under presumptive eligibility is quite low. I think it's capped at $250 currently, but as they go through the screening process, it opens up more services for them. In terms of what we're imagining for presumptive eligibility as we expand it to our waivers and our community first choice recipients, we believe it will still be a lower benefit, but it will be a much wider benefit. And so really hoping that we'll be able to put into place some key services like PERS, some limited personal care services, really depending upon the individual's needs at the time. So we don't have the answers yet because we haven't finished and we are still in negotiations with CMS on what they will approve or not approve, but I think it's looking really positive that we will be able to move forward.
Very good. All right. Thank you, Ms. Kinnaman. Representative Robbins, did you have a follow-up?
I do. Thank you, Madam Chair. To Ms. Kinnaman again, if you don't mind. So one of the things you referenced a couple times was that there's institutional bias in that are sort of embedded in the current long-term services and supports, and you're trying to address that by using the presumptive eligibility. Could you just explain to me what you mean by that?
Ms. Kinnaman.
Certainly. Thank you, Madam Chair and Representative Robbins. So essentially, when somebody can go into a nursing facility, they can be admitted quickly into a nursing facility. And, you know, while somebody is making that eligibility determination for medical assistance, they can still receive those services because they're in that institutional skilled nursing setting. And when the eligibility is determined in nursing facility situations, Medicaid can be retroactive back to the date of admission to the nursing home. Unfortunately, with home and community-based services, that's not the case because CMS doesn't allow us to pay for services until we have an approved person-centered service plan. Everything's been signed, we have our providers in place, and we've completed that full assessment. And unfortunately, I don't know how what the delay might look like in Minnesota, but in Washington, you know, our assessments are booked out several weeks. And so that time period between when a person first approaches us and says, I need the care, to when we can actually authorize and start paying for the care can be quite a long time.
Madam Chair.
Ms. Kinnaman, I'm sorry, I think we might have lost Ms. Kinnaman there for briefly.
And it's that gap, I think, that we're trying to address and get those services.
All right, I'm sorry, Ms. Kinnaman, we lost you briefly for a minute. You might want to back up just a little bit to that last 30 seconds or so. I think we lost you.
So I think probably what I was saying during the last 30 seconds was that
we may have an unstable connection.
Why don't we go to Ms.
I think I'm good, Madam Chair. Thank you.
Yeah. All right. Well, thank you, Representative Robbins, and we'll hopefully Ms. Kinnaman will be able to get her feedback. And with that, we will move on to Representative Albright.
Thank you, Madam Chair. I do have a couple of questions for Ms. Kinnaman. I'm hoping that her connection is stable.
See, do we have her back?
I see her on screen.
Back.
Thank you.
All right, we have her
Sorry
back.
about that.
Thank you, Madam Chair.
No problem.
Ms. Kinnaman, you first talked about kind of this interview that you have with the individual and the individual collecting this data, income, that type of thing. Is there any, you said self-attestation on this, but is there any validation to follow up and verify that data?
Ms. Kinnaman.
Madam Chair, Representative Albright. Yes, we do follow up and verify the data that people are self-attesting to during that early screening. And so the way it works with our MAC and TSOA programs is the initial screening for functional eligibility is not done by our DSHS staff. It's done through our area agencies on aging. And that information is sent to our DSHS staff who do verify that the person meets nursing facility level of care. And then on the financial eligibility side, we ask the client to submit it's not necessarily Medicaid, but an application for the benefit. And then we have financial program staff that go through that application and then determine if the client is actually eligible or ineligible for the benefit.
Thank you, Madam Chair. Ms. Kinnaman, in Washington State, we just heard a bill presenting about the MA spend down. And just for a comparison in terms of how this plan, this policy coordinates with your own MA, what is your threshold for MA spend down, particularly for the elderly and those with disabilities? And how does that fit with this program?
Ms. Kinnaman.
Thank you. I wondered if you would ask that question. So we do have a spend down program, a medically needy program in Washington State. Unfortunately, it's even lower than you have here in Minnesota. So I'm very envious that you have already raised it to 100% of the federal poverty level. So our spend down currently is set at the SSI payment standard, which is around 74 to 80% of the federal poverty level. So yeah, much lower than you have here in Minnesota.
All right, Representative Albright.
Thank you, Madam Chair. And follow-on question for Ms. George, if she's still here.
Ms. George, I believe, is still here, just slightly off camera.
Yes, here I am.
All right, Representative Albright.
Thank you, Madam Chair. Ms. George, you mentioned that Indiana is implementing a pilot program. And there was some suggestion that it costs 5 times more based upon what their findings have been to take care of an individual in a nursing home. Can you tell me a little bit more about what the Indiana program in their pilot hopes to achieve and or demonstrate?
Yeah, Madam Chair and Representative Albright, I might have to follow up with you again on the specifics of the Indiana pilot. Our national office, our Public Policy Institute, did host a whole series with different states on this particular issue, and that's how we met Catherine Kinnaman. But I believe in Indiana they used some emergency pandemic authority to quickly use a presumptive eligibility policy. And I think they are having success with that as well. They're showing savings too. So I could follow up with you on that. But one of the things that I had quoted was the cost to nursing home care. Generally, this is national research that shows that it's about 1/3 the cost of caring for someone in the home. So we do think it is a very cost-effective strategy to try to get people into the care into their homes, first and foremost, but also that's where, seniors want to live. I think some of the things that we do in Minnesota are really good, but what we have currently right now is we have good, effective programs, but it's reaching back to people who've already gone into the nursing home to get them back into the community. So we're kind of hopeful that this sort of presumptive eligibility policy might even be able to bypass a lot of the work that we're doing on the back end and put our energy in the front end. So I'd love to follow up with you though on some of the statistics, because I do have them from the Indiana project.
Thank you, Ms. George. And I suspect there are a number of members who would be very interested in that information. So perhaps we can get that to our committee administrator and she can disseminate that information for other members, because I'm guessing there's quite a few folks here who would also be fascinated by that information. Representative Albright, did you have any additional follow-up?
I do, and it's actually for the author, Representative Schultz, Chair Schultz. With this bill, and we've heard about the program in Washington State as well as Indiana, and it appears to me like both of those are pilot programs. But as I read your bill, I don't see pilot program anywhere in the verbiage. And so are you suggesting that we are implementing a full-scale attempt at this, or is this something I'm missing, and that you're intending for a pilot program first to, in a sense, shake the program out a little bit and make sure that it runs correctly before we move into a more expansive attempt at this across the state?
Representative Schultz.
Thank you, Representative Albright. My understanding, and Mary Jo George could correct me, but a waiver program is a pilot. You're asking for a temporary waiver to implement an innovative program. So in my understanding, when you ask for a waiver, it is like a pilot program, but I'll defer to Ms. George.
Ms. George, did you want to comment?
Sure, and Madam Chair, Representative Albright, my understanding is in all the other 5 states, they're not pilot programs. The waiver, as I understand it, is an innovative approach and a way to waive traditional medical assistance rules, but it was only Indiana that was a pilot, so they haven't completely done that. At this point, Representative Albright, I think we are really interested in working with DHS to figure out if we could look at this policy. So we're still in discussion with them, because I think it does need, we need to talk it through. We need to figure out, possibly we start with a smaller benefit set rather than doing, and maybe we just look at financial at one point or functional in different programs. So I think, as Catherine Kinnaman kind of indicated, they started with some smaller benefit sets, and I think we're open to that. But what this bill does is give our department authority to seek the waiver from CMS, and I do believe we have to have continuing ongoing discussion on how we get there and what can we agree to.
Thank you, Ms. George. Representative Albright, anything further?
Thank you, Madam Chair, and to Representative Chair Schultz on this matter. I think the response that Ms. George provided, I think, gives us evidence that it's much. The waiver does establish a pilot, and so the benefit set. I would urge you to consider a small benefit set to refine it and make sure that we're not stepping out on unproven ground before we make sure that the benefit set is appropriate and that we're finding the results that others have found. So thank you for the testimony and for bringing this bill forward.
Certainly. And if I may add, the one thing that I appreciate that Ms. Kinnaman brought forward, for those of you who do not know, one of my roles out in my daily life is working with a lot of folks who are experts on things like continuous improvement and process improvement, and looking very carefully at how we streamline benefits. And I noticed in Ms. Kinnaman's approach that she spoke of a tiered approach, right? And so folks coming in on that presumptive eligibility enter in on that first tier, which has a much lower cost of entry and a much lower risk until they've been fully verified. And then that expands open the doors to some of those additional tiers, which of course reduces risk for the state. So I'm really grateful for her mentioning that. And I do think that certainly if we proceed forward, that would be a great way for us to proceed as well. So thank you for that. And Representative Liebling, you have a question as well.
Oh, thank you. Thank you, Madam Chair. And thanks, Representative Schultz, for bringing this. I think this is very compelling. I really appreciate hearing from Ms. Kinnaman, taking her time to come all the way to Minnesota, so to speak, and testify here with us and tell us what they're doing. So I just want to confirm if I'm understanding this properly, because it sounds like what this is really doing is aligning the eligibility process that we already do for nursing facilities, for institutional care. I was really compelled by that explanation. Whoever asked the question, I think it was Representative Robbins, to explain what she meant by the institutional bias. So it sounds to me like this attempts to align the process so that so it's not really a new thing, but it has to be a little bit different because the service choices are different. And so, you know, I appreciate where you're going, Representative Albright, with wanting to sort of pilot it. But what I would say, though, is it sounds to me, too, like the one thing you need to make sure you do is have enough initial benefits that you actually keep people out of the nursing home. And it sounds to me like this is really would fit very well with what we do in Minnesota, because as everybody here knows, I think Minnesota for many, many years has had a relatively low nursing home population because we have emphasized home and community-based services for many years and tried to keep people out of nursing facilities. And it's been very successful. And when I've gone to national meetings and heard about this, Minnesota's always mentioned as a leader in this, keeping people out. So I think also something that hasn't been mentioned is the that thing that happened during COVID, where you really need to get people also out of the hospital as quickly as you can, because that also, not only we had, of course, the tremendous overwhelming of our hospitals, but also that's a really expensive place to have somebody when they don't need to be there. So all the things here seem to line up. People don't want to be in nursing homes, as Ms. George said. It saves money to keep them in their homes and to try to ease the path to get them right into their home with the services, even if they turn out not to be eligible later. You know, as has been mentioned, I mean, it just seems to me like this is a really fits in the sweet spot. And just the thing that's amazing to me is that we haven't already done it, honestly, and really appreciate that we're hearing about it today. So thank you very much, everybody.
Thank you, Chair Schultz. And I do know, just for the record, I do know we need to get Chair Schultz on her way because she has another commitment. But honoring that, Representative Albright, do you have something quick before we let Chair Schultz make her closing comments?
Thank you, Madam Chair, and I won't belabor the point. I wanted to just maybe add yes and to Representative Liebling's comments. I think one of the reasons why Minnesota is notable as a leader in healthcare is because we're innovative, but we're also pragmatic about making sure that we don't stub our toe before we step off onto a larger platform. And so I would look forward to seeing the developments of this program based upon that and keeping our kind of a dynamic and gilded figure of being a leader in healthcare intact, because we do think things through in a very thorough and thoughtful way. And I think the testimony as well as the questions have alluded to how we have garnered that reputation, and I look forward to burnishing it further with this program and others that we've heard here this morning. Thank you.
Thank you, Representative Albright, and I will echo some of those comments and certainly appreciate some of those. And with that, Chair Schultz, would you like to give some closing comments so we can get you on your way?
Well, I think Chair Liebling and Representative Albright said that what I would say. So thank you, members, for listening to the bill. Thank you to our testifiers for being here. And, you know, I look forward to working with DHS on some technical assistance and language to clarify some of the questions that were raised here today. But thank you for giving us the opportunity to present the bill. And with that, that's it. So thanks, Vice Chair Bonner, for chairing the rest of the committee.
All right, thank you, Representative Schultz. And Chair Schultz will send her on her way, but with that, we will go ahead and renew the motion to lay over the House File 4096 for possible inclusion. And last on our agenda for today, we do have House File 2283, Representative Albright. And I see that you have a DE1 amendment. Would you prefer to briefly describe your amendment and adopt that?
Thank you, Madam Chair. And members, the DE just updates the dates in the bill from when it was introduced last year. So I would ask for your endorsement of that so we can put the bill in the shape that we would prefer it.
All right. With that, we're going to go ahead and adopt the DE with a voice vote. All those in favor, please say aye.
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 Any opposed? All right. And with that, Representative Albright, we have adopted the DE amendment. If you'd like to go ahead and proceed with explaining your bill.
Thank you, Madam Chair and members. 10 years ago, enabling legislation was passed that allowed PACE, the Program for All-Inclusive Care for the Elderly, to begin in Minnesota. What we're asking now is for funding for a third-party rate study required by CMS to determine the rates available to operationalize the model. Funds are also going to be included for DHS to complete work to prepare for the rate study preparation, as well as some other administrative responsibilities. It should go without saying this, but we are facing a growing and changing senior population that want options. They want choices, and they're looking for a quality of aging that is different from those that have walked that path in the past. We're pleased that this is a model of care that is proven in providing very excellent outcomes in not only the quality of life, but also personalized care. With proven efficiency as a hallmark with high satisfaction, as well as this program has been notable for the flexibility going into the future. This bill, House File 2283, serves seniors by providing a comprehensive, robust, and preventative model of care in the setting that they call home. PACE is a nationally recognized and supported community-based model of interdisciplinary care, big word, for frail older adults, authorized by the Federal Balanced Budget Act of 1997. The BBA established the PACE model of care as a permanent entity within the Medicare program and enables states to provide PACE services to Medicaid patients and beneficiaries as a state plan option. Participation in PACE allows eligible seniors to receive comprehensive services packages that enables them to continue living at home in their community while receiving care rather than needing to move to a nursing home, subject that we just took up. Older adults must be at least 55 years old, live in the community in the PACE site service area, and be certified by the state as eligible for nursing home level care to be enrolled. Madam Chair, with that, I am going to turn over the testimony to Nicole Matson with Care Providers of Minnesota and Wayne Olson with Presbyterian Homes and Services to speak to further details about this bill. And with that, thank you, Chair.
Representative Albright. And just as a procedural motion, I do believe we need to make sure that we establish that we have moved House File 2283 before the committee and that the intention is to lay it over for possible inclusion. I just want to make sure we cross the T's and dot the I's so that we have everything in order. All right, and with
the bill is before us as amended, Madam Chair.
Yes, thank you. As amended, correct. And then Ms. Matson, if you'd like to proceed, state your name for the record and proceed with your testimony.
Thank you. Good morning, Madam Chair and members of the committee. My name is Nicole Matson with Care Providers of Minnesota, and I'm here today along with my colleague, Matt Steele, on behalf of the Long-Term Care Imperative. We appreciate the opportunity to testify today. The Imperative has long been a champion and supporter of PACE as a transformative care delivery model, and we're grateful to Representative Albright for carrying this bill. As the numbers of Minnesotans over 65 grows exponentially in the coming years, we know that innovation is necessary to provide services and supports for all those in need. The community-based, coordinated, comprehensive system of care that a PACE program offers is an alternative option to congregate care. This coordinated, holistic approach to care has proven outcomes for participants and can certainly add additional options to help us ensure that we can meet the needs of our aging population. We have with us today some esteemed long-term care leaders, Wayne Olson, Program Advisor with Presbyterian Homes and Services, and Dr. Joe Gogler, Professor with University of Minnesota School of Public Health. And I really wanted to prioritize their time so that they can discuss the PACE program in more detail and what this bill is attempting to achieve. So I'll turn it over to Wayne.
All right. Mr. Olson, if you'd like to state your name and proceed with your testimony.
Good morning. My name is Wayne Olson. I'm a program advisor with Presbyterian Homes and Services of Minnesota. Madam Chair and committee members, as has been shared not only previously, but in the previous discussions, the number of frail seniors will increase significantly in the next 10 to 15 years. This will put a significant strain on our existing legacy senior care capacity, and also an increasing challenge of our labor service base. PACE has proven an innovative option which is available to assist us to address this expanding need. PACE successfully serves primarily dual eligible individuals facing increased medical and emotional challenges of finding positive aging. PACE provides personalized care designed to maintain their maximum independence in the place they want to call home. Often, our seniors have in the past relied on family, churches, fraternal organizations for help and support as they age. All of these supports are not as robust as they were in the past. As the informal support declines, we also see that the medical and emotional issues faced by seniors are becoming more significant and complex. The challenge of receiving and providing support services are also being made more challenging with the increased diversity of language and culture of our seniors in Minnesota. PACE wraps personalized services for seniors' well-being in the partnership with families, if available, to prevent burnout and give relief to our informal caregivers. Our informal caregivers are most often women, trying to balance family, work responsibility, and core commitments made to their loved ones to help them maintain their independence in later years that they desperately want to honor. PACE services are expansive, mostly located as a day service in a central building, a day center, if you will. That includes full clinic services, bathing facilities, nutritional services, social integration, physical therapies, social work, home health care service coordination, and a full transportation system. In other models, these services are often third-party relationships. In PACE, they're organized as sponsor-controlled, with many of the services supplemented by partnering with existing community partners and services. Typically, the seniors visit the central site, service center site, 2 to 3 times a week. We have seen in the last 2 years that PACE focus on services in home has lowered the infectious disease spread of COVID. PACE experienced 1/3 of the infection rate of COVID and 1/3 of the death rate compared to nursing homes, which of course is due to the congregate setting nature of a nursing home. This model is designed with flexibility, allowing for PACE to pivot on service provision. During COVID, being unique in many service models, participation in PACE has expanded over the last 2 years. Due to focus on individual care that is providing the needed care when it's needed to be provided and where it's needed to be provided, the efficiency created allows for services with less labor requirements. Generally, PACE programs use 50% of the FTEs that a nursing home uses to provide services. In an era where labor shortages are significant and show no signs of reduction or even our existing capacity, I would propose that service models that use less staff create additional advantages for the future. The funding for this program is a combination of Medicare and state Medicaid. The rate study we are requesting funding for identifies service costs that would be expected to be paid by the state granularly down to the county. The Medicaid portion of the rate cannot, by CMS regulations, be more than what would be expected to be expended. Often in states, we see savings that range between 5 and 8% over what would be anticipated to be expended. The rate is all inclusive, covering all costs for medical needs and related social determinants. The key to success of PACE is alignment of incentives. For our elders who want to remain living in the community, the state that wants to save money in an escalating labor environment, and a sponsor who focuses on wellness and preventative care to avoid expensive, avoidable hospitalizations or preventable long-term nursing home placement. As there are often needs for hospital stays and procedures and some needs for nursing home stays, the sponsor retains full financial obligation. Many providers in Minnesota Senior Services believe, with the proven experience in other states, that the innovation that is provided by PACE will be a positive addition to the state's efforts to meet future needs for the flexibility of our seniors, allowing us to serve seniors with increased frailties that are challenged to live independently with increasingly complex and diverse seniors that we are dedicated to serve. Thank you for your time this morning, and specifically thank you, Representative Albright, for your interest and support of this bill.
All right. Thank you, Mr. Olson. And it looks like we do have one additional testifier, Dr. Gaukler.
Yes.
Hopefully I'm saying that correctly.
You got it close enough. Thank you.
All right. If you want to go ahead and state your name and proceed.
Very good. Madam Chair, members of the committee, thanks so much for having me here today. My name is Joe Gaukler. I hold what's called the Robert L. Kane Endowed Chair in Long-Term Care and Aging here in the School of Public Health at the University of Minnesota. I also direct our Center for Healthy Aging and Innovation. And I'm really excited to be here to talk more about PACE and its potential in Minnesota. And you've heard testimony earlier today already about how Minnesota is seen, and rightfully so, as an exemplar in terms of the quality of its community-based long-term services and supports. I think many of you know the AARP puts out a report card each year where it ranks states in terms of the quality of its long-term services and supports. And Minnesota is routinely number 1 or number 2. Interestingly enough, our main competitor is often the state of Washington. So as a researcher who's interested in the quality of long-term care as it's provided, particularly to older people living at home and their caregiving families, it's always been a surprise to me, if not a shock, as to why this state doesn't have PACE. And the reason why I say that is, to me, to many others in the space of geriatrics and gerontology, PACE is the gold standard. It's the gold standard model of community-based services and supports. And the reason why that is, and I think it's a term that's important to remember when we consider PACE, is its ability to integration. It effectively integrates acute and chronic services underneath one programmatic umbrella. Often that umbrella happens to be an adult day program or a similar type of community program. And why that is seen, I think, as an innovation in advance is that when we consider the type of care that older people often receive in our standard healthcare system, it is not integrated. It's often oriented around largely acute care approaches. And because of that, older persons who have complex co-occurring chronic conditions may be at risk for certain types of adverse health events, whether it's hospital readmission, entering a nursing home, a number of other types of issues and problems that I think we're all well aware of. So coming at this from a scientific standpoint, what does the research say about PACE? And you heard Mr. Olson summarize some of this already, as well as Representative Albright. PACE's effects have been evident across a range of key outcomes. This includes not just potentially reducing nursing home admissions, but also reducing hospitalizations, lower costs via capitation outlays. Another interesting study I found, and again, I'm happy to share these studies with the committee if you'd like. One study actually compared job satisfaction amongst nursing assistants in PACE versus those in the nursing home. And job satisfaction was significantly higher amongst those in PACE. And when we consider the extreme challenges of our geriatric workforce, recruitment and retention across the LTSS system in this state and others, having findings like that, I think, are very encouraging. I think another finding, and you heard Mr. Olson refer to this before as well, is I've been really impressed how PACE was able to pivot during the pandemic. Unlike many other community-based long-term services and supports, many of which were shut down entirely, such as adult day programs in this state and many others, was PACE was able to pivot to the providing services in the home setting, and as Mr. Olson mentioned, was able to maintain or actually increase its enrollment within its programs. So, you know, when we consider this state, when we consider the legacy of Minnesota in innovation and long-term services and supports, I think beginning the process of ensconcing PACE here in Minnesota is a worthwhile one, and one I heartily support. So I'll leave it at that.
Thank you, Dr. Gogler. Appreciate
Joe is fine too. That's okay. So yeah.
All right, wonderful. Well, thank you for that information. And certainly, if you have more information on those pieces, Dr. Gogler, if you want to go ahead and send them to Ms. Vang and Ms. Hanson, our committee administrators, we can make sure that members get access to that information as well, because I'm sure there will be interest for sure. So thank you with that. Do we have any questions from members? It's looking very quiet today. Surely there, Representative Liebling.
Thank you, Madam Chair. And just first of all, thank you very much. Very interesting presentation. Appreciate that. I don't know if I missed this, but I just wonder, how does the state pay for these services? Is it a capitated rate? Is it a, you know, could you just explain that? I know it's perhaps not so directly related to the bill right now, but just curious about how that works. And thank you, Representative Albright, for bringing this. I'll just turn off my camera and listen to the answer.
Thank you, Representative Albright.
I'm not an attorney and I don't play one on TV, so I'm going to defer that response to either Mr. Olson or Ms. Mattson.
All right. Ms. Mattson, if you'd like to go ahead.
Yeah, thank you, Madam Chair, and Representative Liebling. And perhaps Mr. Olson can explain better than I, but it is a capitated system that pays per member per month. So it's pooling a capitated rate from multiple funding sources, Med D, Med A and B, Medicaid, private pay into one rate component. And if Dr. Gogler or Mr. Olson has anything additional to add, I'd welcome.
Sure.
Right.
Yeah, if it's okay. Thank you. I would just add that that really is core to the request for this bill, is that this third-party study that identifies what the rate would be drills down by county to determine what that population, which would be served by PACE, would be expected, or based on history, would be expected to expend going forward. So what it does is it carves out existing costs in the system and says this is the rate that would be identified to provide services, again, down to the county level. It'll be different in Morrison County than it will be in Ramsey County. And this study will provide that. That then becomes a part of the rate, as Nicole just said, as well as Medicare, as well as some of the other components. And it becomes a totally funded system using existing dollars, and has an opportunity to see some savings, which are generated by what Dr. Gaugler identified of being able to prevent hospitalizations, which is well documented, as well as to not prevent, but to defer placement in nursing homes and other expensive options until those levels of care are really the appropriate option. So it is really key to the bill that Representative Albright has brought forward and the reason that we need that study.
Very good, thank you. Any other member questions for today?
Madam Chair, may I make one additional point? And this is related.
Absolutely. Dr. Gaugler.
Thank you. And this is related to some of these studies I'm going to share with you that I found was really interesting. Is if you look at the studies of PACE, many of them are older. Some of them are 20 years or more older. And at one level, you may say, well, boy, this is outdated. What is the matter? Why aren't there more recent studies? But the reason is I think PACE has been accepted as it does work. You know, it should be disseminated and scaled up, and the need for additional research on this model probably isn't all that necessary at this point anymore. So I think that's an important point to note here when we think of PACE and where it sits along the continuum of these other LTSS innovations, where in fact, I would argue the research evidence for them and their quote unquote cost savings is less established.
Thank you, Dr. Gaugler, for that additional context. Do we have any additional questions from members? If not, I am going to give Representative Abler an opportunity, or Representative Albright, excuse me, one last opportunity to share with the committee some closing remarks before we go ahead and lay over the bill as amended. Representative Albright.
Thank you, Madam Chair. I think it's evident by the testimony that we have heard on this bill that obviously there is a system that can prevail in providing better options, providing better care, and candidly doing it in a much more efficient way. And as Dr. Gaugler said, the evidence is overwhelming that the PACE program does work. And I would urge members to embrace this. It's being laid over. But I urge members to look into the details even further. I think the evidence is overwhelming in support of this bill as we move forward. So thank you for that, Madam Chair and members.
All right. Well, thank you to each of the testifiers and to Representative Albright for bringing this forward. With that, we will in fact lay this bill over for possible inclusion as amended. And with that, I think we are close to the end of our business for today. Just for members' own information, our next meeting will again be tomorrow, Thursday, March 10th. And as a quick update, I will also say also my sister's birthday. So that must be the time of that year, or the time of year for that. With that, members, we will go ahead and give back just a few minutes of your time for today. And with that, we are adjourned.